Good morning, everyone, and welcome to this Thursday morning webinar. I'm Chloe Tetro. I'm the coaching lead with Ready Care. For this morning's topic, we're going to be looking at managing PCOS, or polycystic ovarian syndrome. We're going to be running through what is polycystic ovarian syndrome, some of the diagnostic criteria, the link between polycystic ovarian syndrome and insulin, and our solution, as always, is low carb and polycystic ovarian syndrome. How does low carb positively impact the management and the symptoms of polycystic ovarian syndrome? So to start off with, I suppose for those that wouldn't be overly familiar, that may have heard the terminology polycystic ovarian syndrome, which also goes by PCOS, which is probably what I'll end up saying for the rest of the webinar because it's quite a mouthful otherwise. So it's a complex endocrine disorder, endocrine hormonal disorder that affects about 5% to 10% of women of reproductive age worldwide. So it's actually the most common hormonal disorder in women. The condition would be characterized by a combination of symptoms that can vary very, very much person by person. But some of the hallmark features of PCOS would be an irregular menstrual cycle, what's called hyperandrogenism, which is a mouthful way of saying excess levels of male hormones like testosterone in the system. And of course, the presence of these multiple cysts where the condition gets its name. So multiple cysts around the ovaries. So PCOS is a leading cause of infertility due to anovulation or no ovulation, where the ovaries don't regularly release eggs. So this disruption in the ovulation process can lead to irregular and absent periods, and that makes it incredibly difficult then for women to conceive. PCOS is associated with lots of different metabolic complications. And for those of you that would watch our talks, you'll start to see there's particular patterns to these things. So there's insulin resistance, and with insulin resistance goes the host of gorgeous conditions that come with it, things like obesity or incredible difficulty in losing weight, risk factors for type 2 diabetes, and of course, with that, an increased risk of cardiovascular disease. So the disorder is often very, very much linked with insulin resistance, where the body cells become less responsive to insulin, which leads to higher insulin levels in the actual circulating blood. So this hyperinsulinemia, high levels of insulin, contribute to the overproduction of androgens by the ovaries, which makes the symptoms of polycystic ovarian syndrome worse. It's also associated with a range of symptoms beyond just the reproductive health issues. You have things like what's called hirsutism, which is excessive hair growth. And this can happen in around the face area. It can happen around the chest area. It can happen in by the belly button, those types of areas, sometimes the arms. Typically, where male pattern hair growth would be associated with polycystic ovarian syndrome, there can be some of that as well in women. Things like acne. So again, around the face, the back, the chest, the weight gain that goes with insulin resistance. And actually, interestingly enough, there's a massive link with mental health challenges, such as severe anxiety and depression, which would correlate an awful lot with polycystic ovarian syndrome. So there's an awful lot of different types of ways it can manifest itself, and it can make the management of polycystic ovarian syndrome quite challenging, and quite challenging to diagnose in the first place. So let's have a quick look at some of the diagnostic criteria involved. So, oops, my wrong little sticker. There we go. Diagnostic criteria. So diagnostic criteria would be how somebody in the medical field would pin down that what you may be experiencing is in fact polycystic ovarian syndrome. So it can be quite complex, as I've mentioned, because there are such a wide range of symptoms and their overlap with other conditions. So things like acne could be something related to gut health. Things like mental health issues could be related to lifestyle, environmental factors, or again, actually gut health. The most commonly used diagnostic criteria with PCOS are the Rotterdam criteria. It's like the city, which was established in 2003 by a consensus of medical experts. So, according to the Rotterdam criteria, a diagnosis of polycystic ovarian syndrome is made when at least 2 of the following 3 are there. And actually, I have some slides on this I can share with you guys. So, hyperandrogenism, which is a state of excessive androgens, male hormone expression. You would have things like the hirsutism that we spoke about. So that's an elevated levels of androgens, either clinically or biochemically. Clinically, hyperandrogenism can manifest in that hair growth, particularly on the face and body. It can manifest in acne, male pattern baldness actually as well. There can be some hair loss as well as hair growth. Biochemically, it's confirmed through blood tests, which show elevated levels of testosterone and other androgens. Things like oligoanovulation, which is quite the mouthful. So little or no menstruation, infrequent, absent ovulation, which can result in irregular menstrual cycles, or amenorrhea, which is the terminology for total absence of menstruation. So women with polycystic ovarian syndrome will often experience cycles that are longer than the kind of top limit of what's considered a normal range of menstruation cycle days. So that would be 35 days and above, or have fewer than 8 periods per year. So that's a good sign that if you can resonate with some of that, there may be some polycystic ovarian syndrome happening there. And then, of course, the definition name of the condition, so the presence of multiple cysts on the ovaries, which would be detected through ultrasound imaging. So these cysts are actually immature follicles that have failed to ovulate. Polycystic ovaries would typically be defined as having 12 or more follicles in each ovary, measuring between 2 and 9 millimeters in diameter, or an ovarian volume greater than 10 centimeters. Those are the main type of criteria, and I'll just pop through those. Actually, we don't need to have a look at those. So it's important to note that other conditions must be excluded, of course, before the polycystic ovarian diagnosis is confirmed. So things like thyroid disorder, is there a little bit of overactive, underactive? Because that can play, that can interplay in your whole endocrine system. Non-classical congenital adrenal hyperplasia, which again is a big mouthful, which can often present with similar symptoms. So the Rotterdam criteria, that three-part criteria, trifecta criteria, that allows for a range of polycystic ovarian syndrome phenotypes, meaning that not all women with PCOS will have the same symptoms or experience them to the same degree. And that's really, really important to notice. Yes, there are similarities, but no 2 women will experience polycystic ovarian syndrome totally the same because of the cocktail of hormones and lifestyle factors that go along with that. Some women may have polycystic ovaries and irregular periods without hyperandrogenism, while others can have hirsutism, hyperandrogenism, and regular periods. So there's no kind of one size fits all with it, but it's a very, very handy criteria if you're starting to think, this is seeming a little bit familiar. So the Rotterdam criteria is widely accepted. There are other diagnostic frameworks like the National Institute of Health, or the NIH criteria, and the Androgen Excess Society criteria. So they can be used depending on where you're going for testing. So with the complexity of polycystic ovarian syndrome, you really need to have a thorough clinical evaluation to pin it down. So this includes a detailed medical history, There'll likely be a physical examination and appropriate laboratory tests that will go along with that. The early diagnosis is really critical in managing polycystic ovarian syndrome effectively. It'll allow for a more timely intervention to address some of the symptoms and prevent some of the long-term complications, things like infertility, metabolic syndrome, which we're going to touch on a little bit more here, and of course the knock-on effect of the both of those, which would be cardiovascular disease risk factors going up. So let's have a quick look at the link. If you guys have questions, by the way, so I know there's a few of you tuned in. If you have questions, work away with the comment section. I'll do my best to answer them, and if I can't answer them and it's beyond the scope of what I can cover, I can ask our doctor to answer your questions, and I'll be in touch with you guys. So what is that link between insulin resistance and polycystic ovarian syndrome? So insulin resistance, if there's one major takeaway for you guys, it is that it is a central feature of polycystic ovarian syndrome. And actually it affects up to 70% of women with the condition, regardless of their body weight. So oftentimes we think of insulin resistance and metabolic difficulties, and we think of an individual carrying excess weight or finding it very difficult to lose weight. And although that's one of the major topologies of this condition, sometimes some women have no difficulty with weight. As we said, there's no two cases exactly the same here. So insulin is a hormone produced by the pancreas that allows cells to absorb glucose from the bloodstream for energy when all is going well. In insulin resistance, the body's cells become less responsive to this insulin, and that forces the pancreas to produce more and more and more insulin to try to achieve that same effect. So this leads to what's called hyperinsulinemia, or elevated insulin levels in the bloodstream, which has a direct impact on the development and progression of polycystic ovarian syndrome. So the impact on androgen production, one of the main ways insulin resistance affects PCOS, is by stimulating the ovaries to produce more and more androgens like testosterone. So insulin acts in synergy with what's called luteinizing hormone, or LH, to increase androgen production in the ovarian cells. So that elevated androgen levels contribute to some of the hallmark symptoms like the acne and the excessive hair growth and the lack of periods. So that disruption of ovulation in a high insulin state also interferes with normal ovarian function by disrupting that balance of hormone needed for ovulation. And it's a very, very delicate and sensitive balance. So that insulin resistance can lead to an excess of insulin-like growth factor, or what's called IGF-1, which further stimulates, it's kind of this vicious cycle. It further stimulates androgen production and inhibits the normal maturation of follicles. So remember a while ago when we talked about the cysts are actually a lump of follicular cells. So the word cyst doesn't really accurately describe what's happening. They're closer to a bunch of follicular cells that grow in these kind of lump-like formations. So this process results in that forming of these small immature follicles, which don't release the eggs and contribute to that characteristic PCOS appearance of these cysts on the ovaries. Now, one of the factors that I hear an awful lot with working with clients with polycystic ovarian syndrome is the link to obesity, weight loss difficulties, and metabolic syndrome. So insulin resistance is very, very closely linked to obesity, particularly abdominal obesity, which is common in women with polycystic ovarian syndrome. Excess visceral fat, so fat around the middle, further exacerbates insulin resistance. It creates a vicious cycle that perpetuates the symptoms and increases the risk of developing metabolic syndrome, which will be the cluster conditions, things like hypertension, blood pressure, abnormal cholesterol levels, and an increased waist circumference. Now, One of the biggest things to remember with insulin is it is a fat storage hormone. And wherever there's excess insulin in the body, it is sending a physiological signal to your body to not only try to create more body fat, it wants to store more, create more, but it also makes the endeavor of losing weight much more difficult. I would liken it to kind of trying to walk up a muddy hill, and it's very, very muddy, and it's very, very difficult because even if you're going to the gym, even if you're eating what would be deemed health foods, but that are still high in carbohydrates, breaking down to glucose, bringing up the insulin levels, you are going to be putting an awful lot of energy and effort into something where your body is receiving that signal to hold on to body weight. So insulin in the bloodstream at high levels is sending a signal to your body to make it incredibly difficult to lose weight, and it is trying its hardest to store weight. And if you've ever found yourself going, jeepers, why does it seem to be working for everybody else? You know, these different kind of health food swap outs, exercise, but it's that much more difficult for me. There is nothing inherently wrong with you. There is nothing you are doing wrong, but you are trying very, very hard to fight a biochemical signal. And until the source of that signal, which is the elevated insulin levels, is looked at, things are going to be very, very difficult. And that can feel very demotivating and like a losing battle. But just as a takeaway for today, it is not a losing battle. It just means that the rules of the game that would usually apply to people that don't have insulin resistance, things like porridge, whole grains, the addition of fruit, you know, rice, quinoa, millet, all of these foods that have been heralded as these big health foods, they will exacerbate this condition. So there's a different strategy needed, which we'll get on in a second. I've given the game away now quite a bit as to what that strategy might be. Now, another thing that I wanted to touch on here with that link is inflammation and oxidative stress. So insulin resistance and hyperinsulinemia are also associated with chronic, low-grade inflammation and oxidative stress, both of which will play a role in the the physiological parts of polycystic ovarian syndrome. So inflammatory markers, such as what's called C-reactive protein and tumor necrosis factor, are often elevated in women with polycystic ovarian syndrome, which contributes to both insulin resistance and other metabolic disturbances. But really, how do I say this diplomatically? It will contribute to you feeling rubbish in your body, is the plainest way that I can put it. So if your body is operating with really elevated levels of low-grade inflammatory markers, you are likely going to feel inflammation throughout your body, things like digestive inflammation, joint inflammation, pains, aches, feeling uncomfortable in your body, feeling like your digestive system seems to constantly be acting up, your bowel seems to constantly be acting up, and this kind of, you know, pains and aches. And as I'm always harping on about, your day-to-day experience amounts to how you experience all of your days, right? So if you are feeling uncomfortable in your body an awful lot and like things hurt and things feel inflamed, that's an absolutely rubbish way to go about your day for you and for your own experiences. So where there is polycystic ovarian syndrome, but more importantly, for those of you watching that may not fall into the category of those that can have polycystic ovarian syndrome, if you're seeing that there's some of the links and symptoms that we talk about, myself and Andrew, with insulin resistance, and if you're somebody that suffers from an inflammatory condition, be it an autoimmune condition arthritic. Anything that ends in itis usually is, usually is, full stop, is an inflammatory condition. So if you have any itis, colitis, arthritis type of conditions, you will really, really benefit from bringing your insulin levels down, because your levels of C-reactive proteins and inflammatory markers will decrease as your insulin levels decrease. So let's get to the management aspect of things. Low carb and polycystic ovarian syndrome. So low carbohydrate diet is actually increasingly, thankfully, it's increasingly recognized as a really, really effective strategy for managing polycystic ovarian syndrome, particularly with in women with insulin resistance. Remember, I said a while ago, 70%, and I would say that that's a very prudent, that's not the word I'm looking for. I would say that that is less than the actual amount, the word I'm looking for has gone out of my head, have insulin resistance. And I would say of those 30% left, they may just not be getting tested for it. So when you reduce your carbohydrate intake, this dietary approach helps to stabilize blood sugar levels, lower insulin levels, and improve insulin sensitivity, which is what we're trying to do. That's what we're trying to achieve here. All of these are critical for managing these symptoms and potentially reversing some aspects of the condition. And I'll show you some case studies here so that it doesn't look like this is all a kind of theoretical approach to things. And I'm thinking particularly where infertility has been an issue. So I'll show you a couple of case studies in a second, but reducing your insulin levels, carbohydrates, particularly refined carbohydrates and sugars, have the most significant impact on blood glucose and insulin levels. Now, the line we always tell people, all carbohydrates, doesn't matter if they're the brown version, the whole wheat version, the whole grain version, all carbohydrates convert down into glucose in the bloodstream. When you consume carbohydrates, they're broken down into glucose, which then go into your bloodstream, which triggers the pancreas to release insulin to help the cells absorb glucose. Now, whenever there's insulin resistance, this process doesn't work as well. It's less efficient, and it leads to higher and higher and higher levels of insulin because your body can't quite manage. So it'll go, okay, let's just make more, let's just make more, let's just make more. And wherever there's that high insulin levels in the body, that's causing a host of those conditions. It is also, which I hadn't touched on, well, I'll touch on in a second actually when we get to the weight loss aspect of it again. So one of the major things in looking after your polycystic ovarian syndrome is improving that sensitivity, because wherever there's that sensitivity, the body doesn't need to have to keep producing. By reducing the demand for insulin, the body becomes more efficient at using this hormone, which can help reverse insulin resistance over time. So studies have shown that the low-carb diets can lead to significant improvement in that sensitivity, even in the absence of weight loss. So there's a paper in 2005 by Budden et al., which showed this. This is particularly beneficial for women with PCOS, as improved insulin sensitivity can reduce those androgen levels and promote regular ovulation. Now, the weight loss aspect of it is often recommended as a first-line treatment for polycystic ovarian syndrome, particularly for women who are overweight and obese. It's this kind of cart before the horse approach to things where I'll have chatted to clients that can see that they're carrying excess weight, and they may have been given the instruction of lose some of the weight, and this will help with your polycystic ovarian syndrome management. Now, it's kind of like a truism. It's true, but it's actually the other way around. If you look after your insulin levels, remember it's a fat-storing hormone, you're going to start to lose weight. So it's when you look after that insulin level, the weight is going to be more less challenging to lose and easier for your body to actually not store any more there. So the other thing I was going to touch on there a second ago that popped into my head is When there's high level of insulin, it also disrupts your hunger hormone and your satiation hormone. So the hormone that tells your body when it's hungry, your hormone that tells your body when it's full. When you have excess levels of insulin circulating in the bloodstream, think of it like this giant foghorn, right? Because hormones are messengers. They have a message they're trying to tell your body. And insulin's just like, and the rest of the hormones can't hear each other properly. So how that can contribute to weight gain and disruptive patterns of eating is basically that hunger hormone is all over the place. You can be really, really hungry, then your satiation hormone's going to land on you, you're going to feel stuffed to the gills, and half an hour later, you're hungry again. And that's a very, very common experience for women with polycystic ovarian syndrome or anybody with insulin resistance. What's happening there is these chemical messengers can't hear each other over the loud foghorn of the insulin. So once that comes down, you can really start to trust your own body's hunger, energy, and satiation hormones. It's going to start telling you, I'm hungry now. You can really trust it. You don't have to go, I'm hungry, but I only ate a half an hour ago. I need to starve myself for, a couple of hours onto my next break or whatever it may be. Low carb diets can be a really, really effective tool for weight loss because it helps to control that hunger and reduce overall calorie intake anyway. People naturally undereat by about 500 calories on these types of food protocols. When you stabilize your blood sugar levels and reduce insulin spikes, it decreases cravings for high calorie, high sugar, high processed most of the time. When people talk about cravings, they're very, very rarely talking about craving spinach. Their bodies had a spike and a drop and wants to get back up to that high. So it will start to send signals to crave very sweet foods. As insulin levels decrease then with a low-carb diet, the stimulatory effect on insulin will help with the androgen production in the ovaries. This can lead to lower levels of androgens, and it'll help with the anti-inflammatory aspect of things we discussed a while ago. I just spotted the time, so I'm going to speed myself up a little bit. So you want to be avoiding potatoes, sweet potatoes, grains like rice, breads, pastas, cereals, and bananas. If you're somebody that has cereals and porridge quite a bit in the morning, having things like Greek yogurt, eggs, rashers, anything that isn't grains basically is going to be absolutely brilliant. Above ground vegetables are absolutely perfect to have with meat or meat substitute if you're a vegetarian, eggs, fish, nuts, cheeses, all of these types of foods are absolutely brilliant to have. Berries, rather than the likes of the very sweet fruit like bananas, grapes, apples, and pears, having things like plums, melons, coconut, and any form of berries will be much, much better. Now, what I'm going to do real quick for the last few minutes is I'm going to show you some of our case studies. So there we go. Typical PCOS patients, 32-year-old, obese, polycystic ovarian syndrome, ultrasound, so showed the cysts, and had pre-diabetes, which would be very normal with insulin resistance. Absent ovulation, 5 years trying to conceive with 3 rounds of IVF, was on clomiphene and metformin for management. So 8 weeks into the Ready Care Control, i.e. us, program, this lady was down 19 pounds in 8 weeks over a course of 2 months, down 19 pounds. Scans showed an 80% reduction in cyst size, which is absolutely amazing. Polycystic ovarian syndrome reversed. So the criteria, that Rotterdam criteria, she no longer fit the criteria. And 2 weeks later, she fell pregnant, which is absolutely amazing. We have another one here, which I'll speed through. I'll be speaking like an auctioneer. 30 to 50% of PCOS sufferers are normal weight, so there's not always additional weight. 34-year-old BMI 20 of normal weight, polycystic ovarian syndrome, showed in ultrasound with a pre-diabetes, absent ovulation, 3 years, was on clomiphene for management, 2 months on Ready Care Control, again, 8 weeks, she was only down 1 pound. So the weight aspect of things was not a priority for this lady, but her pre-diabetes was reversed and an ovulation resolved. So she started menstruating again, and 3 months later fell pregnant. So I hope you guys can see that there's really, really something to this. If you're sufferers of polycystic ovarian syndrome or have somebody in your life or your family that is, you can show them this talk and I hope they find it helpful. If you guys have any questions and you'd like to get in touch, do let me know. Otherwise, have a lovely rest of your week. I hope you found that helpful. If you've any comments you'd like to pop in the chat box, work away with it. Otherwise, I will see you guys next week. Tis I'll be on now. Next week again. Where's my little closing slide? We'll see you later, guys. Bye now.